NDOC, and it's my pleasure to be hosting the webinar today. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the land from which I'm joining this meeting. And I would also like to acknowledge traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations. We pay our respects to the elders past and present and extend that respect to any First Nations people present today. Now, it's my real pleasure to introduce today's speaker, Nathan Harrison. Nathan is a PhD candidate at Flinders University and the Flinders Health and Medical Research Institute. He's also a senior research officer at the National Centre for Education and Training on Addiction, or NCETA. Nathan is a behavioural scientist who is passionate about engaging consumers and community members in his research that reduces health disparities. In this webinar, Nathan will be presenting findings from one of his PhD studies in which he examined stakeholder views on how smoking cessation interventions should be embedded in an Australian lung cancer screening program. I'm pleased that during question and answer time, we'll have the opportunity to hear from Dr. Emily Stone. Emily is a respiratory physician and clinician researcher at St Vincent's Hospital in Sydney and at UNSW. Her chief clinical and research interests are in the field of lung cancer screening, multidisciplinary teen care, and tobacco control. Nathan and Emily will take questions from the audience after Nathan's presentation. You can log questions for them using the Q&A function in Zoom. Please do use the Q&A, not the chat. And I will relay as many of those questions as possible to the speakers at the end of the presentation. Nathan, I'll hand over to you now.
Thank you so much, Alice. Thanks for the opportunity to present in the NDOC seminar today. It's a real pleasure to be here and to share some of our work on how smoking cessation might be embedded into the forthcoming lung cancer screening program in Australia. I'll just begin by acknowledging that I'm presenting from Flinders University's Bedford Park campus today, paying my respects to traditional owners of lands, as well as throughout Australia, where we've conducted these national stakeholder studies. I also want to acknowledge that the data I'll present today was generated as part of a broader program of implementation research on lung cancer screening that Associate Professor Nicole Rankin leads at the University of Melbourne. And of course, I want to acknowledge too that doing stakeholder research like this, sitting down for interviews and focus groups, is only possible with the generous time from our stakeholder participants in the two studies that I'll present today. I also want to acknowledge that I'm supported in my PhD through PhD scholarships under MRFF and NHMRC funded work that my team of supervisors lead. I am supervised at Flinders by Professors Billy Benevsky and Jackie Bowden, as well as Nicole that I mentioned, and Professor Christine Paul at the University of Newcastle. But I also just want to quickly acknowledge too the other study co-authors that come from a range of clinical and research and consumer representative backgrounds, and again, that make this sort of work possible. I'm also really pleased that Associate Professor Emily Stone will be joining from that team as well for our Q&A panel today. So what I plan to do in this seminar in the next 35 minutes or so is give you a quick overview on lung cancer screening, what it is and why we'll soon be seeing and hearing more of it in Australia, as well as the need for smoking cessation support as part of the lung cancer screening program. I'll present a couple of examples from what's happening around the world and then jump into some qualitative findings that we've been finding in this pre-implementation Australia work, sharing stakeholders' perspectives on how cessation support can perhaps be offered within the context of lung cancer screening, and hopefully wrap up with a bit of a so what and tell you what I think this might mean for Australia. Just to jump right back to the beginning and talk about why lung cancer is so important, because lung cancer does remain the leading cause of cancer mortality, both in Australia and worldwide. Worldwide, we see about 1.8 million deaths per year, but survival does remain quite poor. Lung cancer is mostly diagnosed at an advanced incurable stage where there are fewer treatment options available. But tobacco use remains the cause of approximately 80% of lung cancer deaths still, despite generally declining smoking rates. And of course, more broadly, the leading behavioural risk factor for cancer burden. I'm a big fan of this graph here, which I think really sums it up. This is 2019 data, a 2019 publication from a Federal Centre group. Now that really shows the successes of tobacco control already, that we've had great success in reducing Australian smoking rates. But there is still a need to reinforce these efforts, of course. This modelling showing that almost 2 million lung cancer deaths have already been prevented over the period 1956 to the projected end of 2100, thanks to tobacco control. But it also shows that lung cancer will continue to be a significant public health concern in Australia. At the time of this publication, it was modelled that achieving zero smoking by 2025 would result in 360,000 more lung cancer deaths being averted by the end of this century. So still lots of work to be doing in tobacco control to be reducing lung cancer burden. We also know that lung cancer outcomes can be improved by implementing lung cancer screening. Now, lung cancer screening happens via low-dose computer tomography or low-dose CT scanning, and there is now moderate certainty evidence summarised in an Australian-led Cochrane review, that's citation to Asha Bonney and her team from last year, that shows that with risk-based selection of people who have tobacco smoking history, targeted lung cancer screening reduces mortality, that is both lung cancer related and all-cause mortality. And international lung cancer screening trials, as well as subsequent real-world lung cancer screening programs, showed evidence of stage shift. So instead of seeing that advanced and curable stage of cancer that I mentioned, we're more likely to see earlier detection of localized and potentially curable disease. Here's an example of what that might actually look like. For example, here, repeat CT scans showing slowly growing nodules that can then be resected and the like. Here's an example from the literature which did lead to a positive outcome and quite early resection as a result of regular monitoring. Now, national lung cancer screening programs are now operating in 7 countries, although there's some eligibility criteria do differ somewhat. So across these 7 countries, but there are a range of other programs as well, regional level programs, as well as implementation and pilot studies. And 2 or 3 other countries now have also made formal commitments to implementing national level lung cancer screening programs. Heard a lot in recent months about England's forthcoming national program too. When it comes to Australia and offering targeted lung cancer screening in Australia, Cancer Australia released in 2020 the results of their lung cancer screening inquiry, which showed, based on modelling and evidence synthesis, that over the first 10 years of potential national lung cancer screening program, more than 70% of detected lung cancers would be diagnosed at an early stage, that having a program would prevent more than 12,000 lung cancer-related deaths, and help us gain up to 50,000 quality adjusted life years. In October of last year, a national program of lung cancer screening was recommended, and a new MBS item was supported by the Medical Services Advisory Committee. And this is quite important here because when we're talking about a targeted lung cancer screening program, this is a program that's defined by age and smoking history. So I've just pulled out the MSAC criteria there. That shows the eligibility as it will apply in Australia. So the participants that will be eligible for lung cancer screening in Australia will be aged between 50 and 70 years, have no signs or symptoms of lung cancer, but have quite a significant cigarette smoking history of at least 30 pack years. And if they have quit, that they be quit within the past 10 years. In May of this year, is that big day for tobacco control, vaping reform, other announcements made by the Minister. The targeted national lung cancer screening program was announced for commencement by mid-2025. Funding commitments in the ballpark of $200+ million announced that day as well. So Australia's national targeted lung cancer screening program will be starting up in the coming years, which is really exciting news. It also presents a new opportunity to be offering smoking cessation support to a potentially high-risk population. We know from trials and implementation studies that approximately half of lung cancer screening participants will report current smoking. And lung cancer screening has really been identified in the literature, summarised in a recent metasynthesis, as a teachable moment. For example, in trials, we see lung cancer screening participants that are more motivated to quit compared to the general population. and that even without any formal smoking cessation intervention or with only brief intervention, motivation to quit and psychosocial outcomes do change. Now, compared to, again, general population rates, there are higher long-term smoking cessation rates documented among lung cancer screening participants, even when they receive brief advice. This has been seen in international literature, and there was Australian data by Professor Henry Marshall published in the past year that shows that active screening for lung cancer does increase smoking abstinence. So again, amongst the sample recruited as part of the Queensland lung cancer screening study, 16% of participants had bio-verified quit rates at 1 year, and about a third at 3 years as well. Again, much higher than general population rates. Now, combining lung cancer screening with smoking abstinence delivers maximum benefit in reducing lung cancer-specific mortality, both cancer risk reduction as well as early detection. This combination really being integral to achieve best population-level outcomes. So then it comes to how to offer this support in lung cancer screening and some of the implementation challenges that we actually see. Now, the Cancer Australia inquiry on lung cancer indicated that smoking cessation was to be an important and integral component of a lung cancer screening program, and that the likely mechanism for this would be via referral to existing smoking cessation programs, particularly the quitline. Now, international guidelines, for example, those that were recently revised by the US Preventative Services Task Force, suggest that in lung cancer screening, connecting participants with evidence-based smoking cessation support is a real priority. It's often been a funding requirement for programs and the like to connect participants during lung cancer screening to smoking cessation interventions. And based on the limited lung cancer screening specific evidence that was available from US and European trials up until 2016, so a slightly older clinical guideline paper now, the two international organizations, this is from SRNT and the Association for the Treatment of Tobacco Use and Dependence, as well, led by Lisa Faceto, published clinical recommendations on what integrated smoking cessation support might actually look like in lung cancer screening. So again, this is slightly older now. It's a 2016 publication, but itself drawing heavily on 2008 updates too. It was suggested that for all participants coming into lung cancer screening and who smoke, they should be encouraged to quit smoking at each lung cancer screening visit, irrespective of the result of their scan. They should be assisted with evidence-based smoking cessation interventions that should combine behavioural intervention and pharmacotherapy, and be supported with follow-up contact, which is quite possible across the lung cancer screening trajectory. It was also recommended that participants who do smoke but are not interested in receiving other smoking cessation interventions at that time should receive behavioural intervention to motivate change in smoking at each lung cancer screening visit. There are further two recommendations as well included in the Faceto guideline that relate to the optimal delivery in terms of delivery platforms and the generation of data to really support this sort of work moving forward. But since then, there's been quite a lot of real-world data generated, again, in implementation studies, trials, as well as regional programs. For example, the Ontario Health Pilot in Canada, which offers integrated cessation treatment to participants on an opt-out basis, combining both in-hospital smoking cessation treatment, face-to-face counselling, as well as referral to other services. Also, quite interestingly, in the US, there's a series of 8 harmonised trials as part of the SCALE collaboration, the smoking cessation at lung examination series of trials there, that tested out a whole range of smoking cessation interventions. For example, quit lines, medications, integrated care, training toolkits, as well as message framing, resources, and the like. And quite importantly, these trials have some harmonised data, as well as a series of implementation and effectiveness designs to really give us evidence on how this can work in practice. I should say some of the SCALE trials have reported a couple pending publication as well. And another really interesting model that's been offered in the UK is the YES trial, or the Yorkshire Enhanced Stop Smoking trial, which really has shown that, this and related work has really shown that offering more intensive interventions, as we would expect in this setting, delivers better outcomes. So participants in the YES study have been provided with 4 weeks of behavioural support, initially through a face-to-face specialist appointment at the time of lung cancer screening, then phone-based support, as well as connection to pharmacotherapy and or commercially available e-cigarettes, depending on participant preference in this UK context. And I will flag these are abstract-only findings presented by FHMRI at World Lung last year, and again, pending publication. But there's also been some really interesting work in potentially looking at some of those other unique aspects of lung cancer screening. The opportunity to see objective feedback as provided on a scan, pictures of participants' heart and lungs, and to provide that in the form of a co-designed intervention, a personalised booklet intervention, as I've included here. These abstract findings suggest higher 3-month quit rates for women, a bit of an interaction effect, but not overall. But again, though, sort of a recognition within these trials too, that achieving 3-month quit rates, of about 30%. Some really impressive cessation outcomes here. There are a range of other considerations when it comes to offering cessation support and sort of doing work amongst this higher risk population. Is that sort of eligible population, the evidence shows, are more likely to endorse potentially avoidant or pessimistic cancer beliefs, and addressing stigma at the time of lung cancer screening or in the lead up to lung cancer screening is particularly important. There are recommendations in the literature that suggest it's important to offer support with appropriate language and tone, so as to not be seen as too pushy or judgmental in service delivery, and to avoid having potentially adverse impacts on lung cancer screening participation. We know that screening programs, they're so dependent on achieving high uptake and participation rates amongst the eligible population in order to maximize both their effectiveness in early detection as well as their cost effectiveness. So some concerns that being seen to be overly focused on smoking cessation or blaming people based on their history of tobacco smoking could be the sort of thing that pushes people off engaging with a program. There's some promising examples of stigma reduction, though, and some US examples of providing information on lung cancer stigma and its negative associations to community health workers in one study. But this sort of consideration being applied right throughout program design. For example, the lung health check model of lung cancer screening in the UK, interestingly, avoiding the word cancer to be seen as more friendly and reducing smoking-related and lung cancer-related stigma that might otherwise creep in to program communications. Here's an example of what that lung health check model actually looks like to increase accessibility and participation in community-based UK settings. This is the truck which parks in shopping centre car parks, really targeting communities with lower socioeconomic advantage to really reduce some of those barriers. And this is also a recent editorial within the Lancet Oncology, which summarised some other stigma reduction efforts within the field of lung cancer, specifically in some of these initiatives that were presented and evaluated at the World Conference on Lung Cancer last month. For those of you that might be from illicit drugs and have been following similar sorts of discussions within the smoking literature too, things as simple as person-first language can have real impact in reducing stigma for participants at higher risk of cancers, but who can so benefit from preventive interventions. The other sort of intervention that is described within this editorial is the language guides being put out by the International Association for the Study of Lung Cancer, and their advocacy and championing of person-centered language to avoid stigmatizing people based on their smoking history. So when it comes to actually implementing lung cancer screening in Australia, there's been a couple of key trials, the first being Queensland Lung Cancer Screening Study, which really showed that screening can be delivered feasibly in Australia. And subsequently, the International Lung Screening Trial that had sites in Brisbane, Perth, Sydney, and Melbourne as part of a team recruiting in Canada and elsewhere too, with follow-up data pending, but lots of important implementation questions being answered through the ILST. Now, when it comes to this forthcoming national lung cancer screening program, which has been announced, this is a really exciting time in that much of the expected delivery model and the like is continuing to be designed and will soon be implemented. And the current information, if you jump online, particularly on the Cancer Australia page, is that further information about implementation will be provided over coming months. So definitely watch this space. It is expected in Australia that the pathway of lung cancer screening delivery will be a mixed model combining private radiology services as well as mobile screening vans, and that will offer low-dose CT scans at 2-year intervals for eligible participants. Here's a photo of a similar model which is currently driving around Queensland, the Heart of Australia bus. Mobile CT is possible, and which hopefully might reduce some of those barriers, as has been tested in the UK model I described earlier as well. But when it comes back to smoking cessation specifically, again, we have some unique opportunities here to provide cessation support in that the National Lung Cancer Screening Program will be Australia's first targeted cancer screening program, as opposed to a population level one, perhaps based only on age, in that eligibility is defined, in addition to age, by smoking history. Now, there are also multiple opportunities and multiple touch points to provide smoking cessation support in the context of lung cancer screening, as has been indicated in the sorts of screening and assessment pathways being drawn up and the like. We also know from international settings that treatment staff is providing cessation support on the ground, are real advocates for screening as well. They consider it an important service to be offering their patient population, for colleagues who might be working in alcohol and other drugs as well, who might have patients who would be eligible for lung cancer screening based on their smoking history, and also really consider that it's something that can be done by cessation treatment staff as well. Routine assessment for lung cancer screening eligibility as well. When it comes to actually putting this into practice on the ground, lung cancer screening implementation is quite complex and requires some context-specific considerations. And some current evidence gaps in Australia is that there's considerable variation in how cessation support is actually delivered between existing programs and little formal guidance at present. As I mentioned, some older 2016 guidelines, older evidence informing what is recommended elsewhere. But the most effective ways of actually integrating routine cessation support into real-world screening, including in Australia, remain unknown, which has really informed some of the qualitative pre-implementation work that our group has been doing. So I'll start by presenting some focus group data collected with health professionals and other stakeholders here, because there are various options used internationally in order to offer smoking cessation support. These might be models of treatment that are integrated within existing services or rely only on external referral approaches, perhaps some sort of combined model. However, how to optimally embed this support in the lung cancer screening context in Australia really does need to be understood. And in this sort of area of implementation science, we know that stakeholders' expert perspectives can be so valuable in identifying guidance of how to overcome potential barriers, identifying strategies to inform effective implementation, as well as telling us about the opportunities to maximize acceptability in program delivery. So this qualitative analysis is based on a series of 24 online focus groups and 3 individual interviews, with a total of 83 clinician and other key stakeholder participants, that was led as part of a broader study led by Dr. Rachel Dodd at the University of Sydney, the Duffield Centre, where we then conducted inductive framework analysis of the transcribed data as applied to smoking cessation, and have mapped findings against the consolidated framework for implementation research here, very widely used model within the implementation science field. So when we asked these participants about their perspectives on if and how smoking cessation support should be offered within the context of lung cancer screening in Australia, stakeholders really expressed strong support for capitalising on what they considered to be a perfect teachable moment for cessation at all contact points and even brief windows during the screening and assessment pathway for lung cancer screening. Having those multiple touch points in the cancer screening program was really considered ideal. As one radiologist participant told us, you've already got your highly concentrated population there. The advantage of doing it is you might get the patients at a good time and they might listen. Now, stakeholders also suggested offering integrated but individualized interventions that were tailored based on sort of determinants they considered quite key to smoking cessation, like cultural factors and participants' perceived readiness to quit. More broadly, going beyond the clinical community-based delivery as well, stakeholders also suggested that having consistent cessation support messaging would be really important to reinforce the messages delivered within a program. For example, using anti-smoking mass media, on-pack warnings, and disseminating messaging through family members and community networks as well to really reinforce what can be done at the point of a scan, for example. Stakeholders also really described a real ethical responsibility to be delivering smoking cessation as a core lung cancer screening component, not just focusing on early detection, but also furthering prevention efforts at the same time. And this extended to offering interventions during the risk assessment for lung cancer screening so that those who might not meet the current parameters of the targeted national program and be ineligible or considered at lower risk would still be able to benefit from cessation support. As one of the respiratory physician participants told us, it's the responsible thing to do to give them items and resources to smoking cessation because that is the right thing to do. Again, really focusing on this perceived ethical responsibility. And stakeholders considered that having dedicated or specialised as well as embedded cessation resources to be quite essential. And that although referral to established programs, clinical and community-based programs, particularly Quitline, would be quite helpful, but that would be particularly appropriate in the context of follow-up support. Still having some sort of face-to-face intervention would be really important. Finally, it was suggested that those attending lung cancer screening, as opposed to others within the eligible population who would not be attending, could potentially represent a more highly motivated subgroup of those eligible who would be more open to receiving cessation advice, and hence trying to target people that might be motivated to do this might provide another recipe for success. And finally, although offering cessation support at every opportunity was important to many stakeholders, some did consider that having persistent or overt offers could potentially overwhelm participants in a screening program. And importantly, that it might discourage their initial or repeat engagement in both screening and cessation. So perhaps if we're having a too overt focus on smoking cessation within lung cancer screening, it might be the sort of thing that puts people off getting involved in the first place. So just to wrap up the findings of this focus group study, as they related to smoking cessation support was considered to be an essential component of a targeted national lung cancer screening program when this data was collected in 2021. Also really highlights that there is openness among Australian clinician and other stakeholders, but also significant opportunities to embed routine offers of cessation support. Also highlighting that locally adapted strategies are also needed. Now, in this study, stakeholders were recruited for their potential involvement in a lung cancer screening program and the implementation of it, but there was a wide range of familiarity with lung cancer screening and smoking cessation specifically. And this analysis was focused on one focus group component as part of a broader study. So it was followed up with in-depth interviews with national tobacco control expert stakeholders on how cessation interventions might be potentially embedded in the national lung cancer screening program. So we sought the perspective of Australian experts on this optimal, the best way to optimally embed cessation interventions into lung cancer screening. Specifically trying to drill down a bit more onto factors that affect acceptability and feasibility, barriers and facilitators to implementation, as well as potential delivery models and implementation strategies here. And we really did this in the context of 3 potential pathways, which really map onto what has been trialed and implemented, particularly in the US context. Some of these that I referred to briefly before was that smoking cessation can be wholly embedded, that is delivered entirely within the context of a lung cancer screening program, coordinated and delivered within that program. Or in contrast, lung cancer screening program staff might provide referral as appropriate to cessation support, but that cessation support would really be delivered by an existing external service separately to the lung cancer screening program. It might be through Quitline, it might be through primary care, or there might be a hybrid model of this support where some services would be embedded within the lung cancer screening program and others might require referral to an external agency. So these are the 3 pathways that we presented expert stakeholder participants with and sought their views on. Again, a total of 30 participants generously gave up their time from practitioner, researcher, and policymaker backgrounds to conduct qualitative reviews, which we again inductively analysed and mapped against the CETA framework. Looking at these 3 potential delivery models, having wholly embedded cessation support in the context of lung cancer screening did attract support from a minority of participants. It was considered to be resource intensive, to have therefore lower feasibility, and as a result, sort of partially embedded or perhaps telehealth models were also suggested. Having wholly external models, again referring out only to existing services, had no outright support amongst the 30 expert participants, as it was considered to be insufficient to engage participants, lung cancer screening participants, for uptake. So this hybrid model was the preference of most, considered to be the sort of model that would maximise cost effectiveness, as well as the extent of cessation support that could be offered here by really connecting to the full suite of options that are out there. And as one stakeholder participant told us, why wouldn't you connect to Quitline and refer people there, a behavioural intervention component, and then ideally they could walk away with appointments and pharmacotherapy at the same time. Now, when it came to qualitative findings more generally, tobacco control experts really, cited the existing smoking cessation resources that had been developed and implemented in Australia, even if not in the lung cancer screening context specifically, but their desire to avoid what they considered to be unnecessary duplication in resource development, really noting that implementation efforts and putting into practice what we already have and adapting it for lung cancer screening would be a priority. One researcher participant described the literal reams of stuff and their frustration that the problem isn't the resources. There are some things out there already. Again, it was often suggested that lung cancer screening presents an opportunity to leverage broader tobacco control initiatives, such as anti-tobacco mass media, and to reinforce the existing strategies we offer in cessation support. Experts also described a range of existing barriers to providing support in their clinical settings. Ones many of us know, competing priorities, time pressures, but also the importance of countering perceived stigma to maximise engagement for this population specifically. It was suggested that to overcome this in future, having specialised training on cessation intervention delivery, having appropriate role clarity, and buy-in from all levels of leadership with appropriate funding commitments would be really important. So really suggesting that having this sort of specialised training would be important, not just drawing on one seminar at med school 20 years ago, as one participant described, but actually having more specialised training on addiction. So just to wrap up, the results of both of these studies together really showing that amongst Australian stakeholder participants, there is strong support here to embed routine offers of cessation support into the forthcoming National Lung Cancer Screening Program. Importantly, doing so in conjunction with existing services and resources to maximise the uptake of those services. It's important to note that broader tobacco control context is important here. Policy opportunities that might assist this, particularly as it applies to a higher risk population who are in part defined by having more than 30 packed years of smoking history. For example, the recent calls for accessible and subsidised combination NRT and supported by a clinical workforce that has dedicated smoking cessation training have been advocated for more generally. Really also highlighting that in Australia now, as we move towards having a lung cancer screening program, identifying, evaluating and adapting the sorts of resources that might be offered to lung cancer screening participants, and importantly, doing so in partnership with eligible participants through processes of co-design and the like, will be really important. So this sort of pre-implementation work as well is really important. Australia has really been considered quite a leader in doing this work to make sure that processes are hopefully right from the start, to identify strategies that can optimally integrate and embed evidence-based smoking cessation interventions in the context of lung cancer screening to maximise uptake and effectiveness. There are real opportunities to deliver, research and subsequent intervention during the design of the National Lung Cancer Screening Program, as the start date really does come up to us. But there are other countries that will be implementing or making formal commitments to lung cancer screening soon that are considering or implementing. A really exciting space to be watching. I know this specific topic and lung cancer screening is something perhaps adjacent to some of the smoking cessation work we might otherwise see. For anyone interested, Tobacco in Australia's chapter on lung cancer screening and biomedical risk assessment can be really great reading, as well as Cancer Australia's feasibility work that was conducted in conjunction with the Department of Health and Aged Care. Very large series of work across different work streams there. Anyone else interested in having a chat? Talking about upcoming research, I'd love to talk more in our subsequent Q&A or offline as well. So thank you again for the opportunity to present some of this work today. I can't believe I'm almost right on the 35 minutes I promised. Usually that's not my strong suit, but it's been a real pleasure to provide a quick overview on lung cancer screening and the need for smoking cessation support within that, as well as these examples from overseas, and hopefully sort of based on the results of these stakeholder studies in Australia, a bit about what this all means. I very much look forward to having more of a chat in the Q&A. Thank you very much.
Thank you, Nathan. That was excellent. Really appreciate you sharing your findings with us. It's really important work, and really look forward to seeing how this does shape the implementation of screening in Australia when it does get implemented. I am now going to invite Emily, our panelist, to turn on her camera and microphone. Hi, Emily. Thanks for joining us. Let's start, Emily, by asking you if you've got any perspectives or additional insights that you might like to add based on what Nathan's just presented.
Thanks, and thank you for a wonderful presentation and the opportunity to join today. Such a terrific presentation, and Nathan always does such a terrific job. What I'm finding as we move towards the implementation of screening is we're really getting down into the nitty-gritty and the detail of our planning. And I had the good fortune to participate as an investigator in the lung screen trial. And it was, a huge effort to actually recruit and to get people screened and eligibility determined. And we really didn't engage in smoking cessation in that trial at all. I will admit to feeling like I didn't have time, although I don't think that's an excuse. But it's certainly been something we've been increasingly aware of in cancer clinics as well as in the screening setting. And it is important just for this audience to know that we don't have a program yet in Australia, although we have trial experience. Coming back to thinking about the smoking cessation, there's enormous amounts of evidence coming, and I think Nathan's done a great job presenting that to us. And it might be that how we do smoking cessation for people coming towards screening differs from how we do or don't do it for people who have cancer or other smoking-related illnesses, and how it's done generally in the community. I suspect that we're going to see signals coming out of the research that tell us that slightly more intense treatments will be more, or approaches will be successful in screening. And I don't think that's confirmed, and I would never dismiss the benefit of a brief message. But, even a paper I had to review, a published paper that I had to review recently from the United States, looked at sort of standard on-site tobacco cessation, then with or without the addition of nicotine replacement, with or without the addition of off-site clinical, off-site, as it were, quitline referral. And the only thing that made a real difference in that screening setting was the intensity of the ongoing support. So I think that the real details are yet to be determined. The screening group are potentially more motivated and are well people, so they're a fantastic group to get hold of. They do have higher smoking rates, we think, than the general population, and even than the lung cancer population, because we know that lung cancer, people with lung cancer, there are more people who've previously smoked than currently smoked. That might not be quite the case for the screening population. Be that as it may, there's so many details to think about in terms of intensity. I'm fascinated by that finding that you had with the focus groups, that there's some concerns about overdoing it, which is not really what's coming through in the therapeutic literature, but we do have to take that into account. So there's lots of things to think about there.
Thanks, Emily. And I can see in the Q&A there's some similar sentiments around, that stigma and potentially putting people off. And in some cases, perhaps thinking that the damage is already done. And
I do think we actually have to test that concept of putting people off, because it's not really coming through in the literature, and not even in my clinical experience, which, if you do it sensitively and well, and I'm by no means an expert, but I've tried to learn over the years. Most of my patients, and a lot of what you see in the literature, is that if it's done well, people who smoke are really grateful for the support.
Yeah, great to know. Okay, well, let's get into the Q&A, and I'll just remind everybody that we've got about 15 minutes. So if there are more questions, please do pop them in there, and hopefully we'll get to them. So one here from Stuart Porter, who would like to hear your thoughts on whether you considered running focus groups for the subjects who met the eligibility criteria for the screening program, and what they thought about it if they were to take up screening.
Sorry, I think I actually missed the key crux of that question. I apologize.
Yeah, no problem. If you thought about running some focus groups, similar ones with people that would be eligible. So, you talked a lot about the different stakeholders, but not so much the people that would end up participating in a screening program.
Absolutely. Thanks, Stuart. That's a really great question. And I think, it's really important to acknowledge that seeking the perspectives of eligible population is so vital to making sure that some of the strategies that might be identified by stakeholders can translate, and testing out that acceptability and feasibility is really important. This particular study was focused on seeking expert stakeholder perspectives, because we also considered that the broader team, as part of this, considered the sorts of health system and participation factors that would be relevant. But yeah, absolutely, I think it's really important to make sure that having participant perspectives is captured. There's some great research being planned and conducted in Australia, as well as overseas. This sort of similar qualitative research in addition to the trials. And I should say that some of the trials that have been conducted as well have really nicely embedded qualitative work. So including from the Queensland group that have really focused on participant perspectives. And some of the things that I think that really jump out, and similar to what Emily was saying before as well, is that eligible participants in Queensland, for example, in that trial, really describe how actually offering a lung cancer screening more generally really helps to feel cared for. In order to, that sort of early detection is something that does seem to mean quite a lot for participants. So I think that's been a really nice finding from the Australian qualitative literature.
Yeah.
And I think some of that might be echoed from the information from the United Kingdom, where the pilot programs are designed as a lung health check model. And I think you referred to that, Nathan, where participants who are identified through their general practices as currently smoking were invited to a program that I think there was a strong effort to destigmatise that wasn't just let's screen you for cancer and let's talk about smoking, but was really involved spirometry and identification of other risk factors, and provided fantastic things that we sometimes struggle to do here, like nursing support, and has had fantastic uptake rates in terms of screening. And I think the research on the impact on smoking rates is ongoing along the lines of what Nathan referred to.
Great to hear. Looking at the questions, you've got lots of compliments, Nathan, but there's not too many more questions. So I might jump in and ask one that I'm wondering about, and that's around your engagement with. So you at the beginning you gave us a list of your great stakeholder group who you're working with, but just wondering how you are going about trying to get your findings to actually influence what will be implemented ultimately.
Yeah, thanks, Alice. It's a really important point, and as we've sort of mentioned today already, that there are sort of significant opportunities to try and capture pre-implementation perspectives and feed them forward, so that the subsequent programs offered in Australia, but also elsewhere, can really help to overcome some of the barriers that might be identified. I mentioned also that Associate Professor Nicole Rankin leads like a larger body of implementation research on this exact topic. And for example, there was another workshop that the team held in July, bringing together some stakeholders from a range of organisations, including from within government and the like, community organisations and consumers as well. And hopefully together that this sort of work can help to inform. We're very, very keen to be reporting as quickly as possible. Very, very keen to present and disseminate reports to agencies that might be interested, as well as to our NGO partners.
Yeah, great. Thanks.
I'm very encouraged by, if I may jump in, just the concepts around engaging the current resources, including in particular Quitline. I think they're possibly quite underutilised in the clinical setting, and I speak for myself in a hospital setting, where I think uptake of that is very variable. I think there is much better training these days for junior clinicians, because my junior doctors are much better at smoking cessation than I was at that stage of training. But I do think that we can improve. And one of the things that came up in a discussion recently, probably more in the context of cancer clinics, but I think it applies to lung cancer screening as well, is that smoking cessation as a pathway is less clear, I think, for many clinicians than other pathways. And I compared it for if someone has chest pain, there's a pathway, or someone has an asthma attack, there's a pathway, or if someone has a lung nodule or a high blood sugar, you almost know which number to call or button to press. But for smoking cessation, I think it's still fragmented. And, I would love to see through, work that Nathan's doing and the other groups, if we could somehow, harmonise the pathways like we try and harmonise data. And I'd love Nathan's or anybody listening's thoughts on that.
Thanks for flagging that, Emily. I think it's a really important point, and I speak as someone within the public health research. I acknowledge I'm not a clinician in saying all of this as well. But I hope that this sort of implementation research can help to identify those barriers and help to in partnership with clinicians provide potential pathways to make sure that there are systems and structures. And I think that many of the barriers that are identified in these sorts of stakeholder samples is that idea that there are significant time pressures. It's hard to know whose job this is, and the sort of common thing within the implementation literature, of course, being that everyone wants it done, but can be
Who
hard
wants
to
to
know
do it?
who wants to do it. So I think that's a really important point to be raising and identifying as a problem to work towards.
Did you detect in the conversations any sense of the need for a mindset change from it's not my job, but it's somebody's job, to it's everybody's job, which is a mindset I wonder if we need?
I think within certainly the focus group data that Rachel and her team were leading as well, I think there's some examples that were cited from particular discipline or specialty groups, stating that it would be particularly hard or expressing a desire to not necessarily want to do the smoking cessation bits of the lung cancer screening assessment. And there's some great quotes within there about wanting GPs or others to really take the lead on that. But there's certainly others within this qualitative data set that really cite their ideas that smoking cessation should be a responsibility for every person involved right throughout the pathway, and importantly at every encounter. That sort of thing does really provide the best possible way to achieve outcomes. So that sort of divide within this particular sample.
And I'm interested in your comment on at every encounter. Last year we did some education programming for the Thoracic Society on smoking cessation, which was fantastically well attended. For the first time at a smoking cessation clinical meeting, we needed a bigger room, so it was very exciting. But one thing that came out of that, really terrific presentations from healthcare workers who are very skilled at motivational interviewing, and that's not doctors, it's not most anyway, it's not me, was that you needed something like an average of over 30 individual interviews, not necessarily long, but moments where that message was given on average before people successfully quit. So it seems to me that, and I really, really appreciate the message around stigma and don't overdo it, but that in fact we need to be very persistent as long as we do it well. And are you planning to look into those sort of that qualitatively, or do you think we were comfortable with that information so far?
Yeah, it's a really important point, isn't it? And I think also that in terms of a natural barrier, I think the one other thing that we do see in this data quite a lot is that many people seem to have an example of trying to initiate a discussion on smoking and getting a negative reaction, and
from the healthcare worker,
from healthcare workers getting that sort of response from a consumer, and it naturally being off-putting. But I think also the recognition too within screening and certainly further down the track into treatment and the like, being that cessation can provide so many benefits at any stage of treatment and the like, of course, as well. And a lot of the stigma reducing literature now really being focused at multi-level targets, that it probably does require not just an increased sense of comfort to have discussions openly and safely, but also the sort of societal level changes that we probably need. People often describe, and I think there's a similar comment that an attendee has described here today about the stigma against people with lung cancer being so blatant. We're not having discussions in the same way we do with pink balloons and cupcakes, and those sorts of changes that might be required in order to support that too.
Thank you, guys. I might wrap us up there. It's been a really great discussion, and thank you, Emily, for asking Nathan a few questions. I think our audience were really pleased with the conversation, but weren't generating that many questions today. So
there's lots more. We could keep going.
Yeah, I'm sure. But yes, I'd just like to say thank you so much to both of you. It's been a fascinating discussion, obviously a really important one, and really appreciate you sharing that with us. And to say thank you to our audience for engaging, for coming with those questions and for your feedback. But before we bring the webinar to a close, I'm just going to let everybody know about our upcoming webinars. So next week we have the NDARC annual research symposium. So we won't be holding a webinar, but we do hope to see many of you at the symposium. And the following week, we welcome Dr. Stephen McGillivray from the University of Dundee, who will be presenting his research on evaluating access, engagement, retention, and successful exit in opioid substitution treatment services and needle and syringe programs. And then the following Thursday, on the 9th of November, we have Samantha College-Frisbee talking about the incidence of injection-related injuries and diseases in and out of prison. I think that's enough from me. I hope everybody enjoyed the webinar, and look forward to having you join us for the next installment in a couple of weeks' time. Have a good afternoon, everyone.